Hi, everybody. Welcome back to another episode of ASAP Pathway Podcast. Your host today, actually, it's kind of like a dual hostess day, Dr. Stacy Ochoa, and then my partner in crime in ASAP Pathway, Dr. Michelle Weddle. So I guess we're technically both hosting today, right?
Yeah, so we've got double hosting.
Double hosting. Um, we wanted to come on today because we get a lot of questions about this and some. I know personally, I'm really excited about this topic and what I could learn moving forward. But Michelle is just so knowledgeable in the realm of many things. But one of the things that she's passionate about is TMJ dysfunction, uh, therapy, and how to intercept, how to manage. She's really progressive. She's been adding a lot of things in her own practice successfully. She's been doing this for years. And we've really been asking her, how do we get this in our own practices? How do we implement this? And we've been pushing and pushing her, please teach this. Please teach this. And I personally, how many times do I say, I'm flying to your office. I'm taking a week. I'm going to observe with you. And finally, we just said, she's like, fine, I'm just going to teach this. I'm like, yeah, you should.
Right, right.
And
Well,
you have a unique component too, because you also look at children's TMJ health too, which is super important. And nobody really is talking about that. So I wanted to just start diving in and just asking you some questions and you give us some information so we better understand like what this course is about that's coming up. The course is basically it's TMJ dysfunction part 1. It's like a foundations course, right?
that's right. It's a foundations course. It's kind of like before you treat something, you need to be able to identify and diagnose. So what information do we need to identify and diagnose?
So
That's
true.
that's what it's about. And TMD or TMJ, there's so many things about TMJ that a lot of people are kind of skittish about, or it's like once you say TMJ, it's like the brain shuts down. It's like, not
It
me.
is. It is such a lot. I'm one of them. It's like, oh, we got to send you out because I don't know what to do with that. And it's intimidating. And we get analysis paralysis. I think for me, it's like, where do I start? And there's a lot of different philosophies out there, right? You've got Panky, people are Dawson trained, you had LVI trained, you have all these different, Spencer Study Club. We've got all these different oral facial medicine clinics teaching. I could go on, but it's
And I
like,
think,
what
yeah,
philosophy? I guess there's just different philosophies that do work.
and that's what makes TMJ confusing until I'm the same way. When I first started, I started with Dawson. I started right out of dental school. Actually, I should back up. I started all of this occlusion. It started with occlusion, right? I started it in dental school because my instructor for occlusion was a Panky trained dentist. And lucky for me, he's just like, after you're done with dental school, immediately after, go to Dawson or Panky. And I kind of listened.
Wow.
And I think it was 2 months out of dental school, and I was sitting in St. Pete with Pete Dawson, with every concept going over my head. I'm just like sitting there with all the dentists around me, and my jaw was just hanging. And I'm just like, I don't understand these words. I don't understand the CR, TMJ, like all of these acronyms. I like, the lateral pterygoid, the medial pterygoid, and you can't palpate it versus you can palpate it. Just I didn't
I know.
understand
Isn't
anything
that
about it.
the
There's so many
question?
controversies.
To to palpate or to not palpate the lateral pterygoid? That is the question, because it is on every form. Like, is there any tenderness with the lateral pterygoid? And you hear schools of thought, well, if you put your finger up here and you do this, you can palpate it. And other people are like, I don't care what you do, you're never touching the lateral pterygoid. Let it go. So it is. It's just TMD is like a Wild West too.
And it's what I learned from Jameson, where, Jameson Spencer, he's got this special talent of just drilling you down to the basics. so that you can start somewhere and start applying it and start helping it. And then from there, you can build your understanding and build your experience. It's like, Angie, 10 holder, she's like, pterygoid area. Like,
Yeah, it's
it's a
like
pterygoid area.
it's
Well,
the area
that
of the
works for
lateral
me.
pterygoid. Yeah, it's good enough. Generalized enough. Yeah.
In that patient, is it on fire when you started, and is it better afterwards? Great. Does the patient care that you're palpating the lateral versus the medial pterygoid? No. Right? It's kind of like sleep. Does the patient care, that you're looking at their iron, and you're looking at prosomnus versus an EMA versus all of these things? They don't care about the details. They care about good sleep.
Yeah.
TMJ patient doesn't care about the lateral pterygoid or the medial pterygoid.
They want quality of life.
Yeah.
Yeah.
Can I eat? Can I yawn? Can I yawn without me feeling like my jaw is going to get stuck open?
Mm-hmm.
Or can I wake up in the morning without feeling like I can't open my mouth?
So just to back it up, even for myself, because I'm really looking forward to all of this myself, but the course TMD Part 1 Foundations, it's May 10th and 11th. Where are you going to start with this? Like, what's the actionable, like, Monday, I'm going to go home and I'm going to be able to, as a dentist, better understand and do what?
So TMD for me has been such a long journey, right? I myself have had TMD issues, headaches, all of that stuff since high school. And so when I went to dental school, I thought, finally, I'm going to be able to help myself. And then I graduated dental school, and lo and behold, I got like 2 hours or 1 hour maybe in TMD. And that was it. So I couldn't help myself. So started the journey of Dawson, and then Panky, and then Coyce, and then Spear. And then I looked at LVI. I looked at all of these things, and then Spencer studied all of that stuff. So what I have put together for a course in May is everything that I've learned from all of these places, kind of drilled down so that it can be applied starting when the attendees go back to their offices. It's going to be practical because, I just, there's so many concepts, like you said, there's so many concepts, there's so many controversies, there's so many philosophies, but if you actually boil them down and drill them down to its foundation, there are many, many things that everybody is saying the same. They're just using different words, or they're approaching it from a different standpoint, but it's pretty similar. So we're going to start there. We're going to start with the basics. We're going to start with, how do you even know what you're looking at? And now with the advent of imaging with CBCTs and MRIs, it's really, I wouldn't say simplified. I would say it's really clear. It makes it more clear. It adds on another dimension where we know what we're dealing with.
Yeah, you're seeing it now. You're seeing it versus, let me guess where the disc is. Let me guess where the joint is within the joint space.
Yeah.
There's no more guesswork. Now, do you have to understand what you're looking at in a CBCT or in an MRI? I guess yes. So
but you don't have to know everything, like right from the beginning, right? There are many, many, like Danya Tamimi is one of our visiting faculties in ASAP Pathway, and she really helps explain the relationship of what we're seeing in the imaging versus what we're seeing clinically, and also kind of where things are coming from, historically speaking, because there's a lot of joints that we're seeing that are or have wear, and they're not currently wearing down. They were in the past, right? So how do you know the difference?
Exactly. When you're looking, it's like, is this currently still happening, or am I seeing evidence of something that happened in the past? Is this something that happened a long time ago and now they're no longer doing it and we don't really need to address it and they're stable? So there's those questions. Also, we just had Dr. Dania Tamimi on, I believe it was this past week, Tuesday, and she was discussing, and I can't wait to see it. It's in the recording. It's recorded in the Zoom library, but apparently she went into going over like what not to do, like when you don't want to expand, correct? Like that's what I'm like, I can't wait to watch that video.
Yeah, so we're looking at stable joints versus unstable joints, right? And when forget about orthodontics, when is it safe for us to do dentistry? Because I am a general dentist, right? I'm not just, but I am not restricted to pediatric airway or adult airway and TMJ. I am still a general dentist. I still see patients restoratively. So when is it safe to see a patient restoratively? When is it safe to place an oral appliance in a patient with sleep apnea? When is it safe to start orthodontics? The joint is a foundation. So if your joint is changing and it's shifting, you're not going to get the bite right. It's going to be very difficult. And your bite is what you base your orthodontics on, and it's also what you base your restorative dentistry on.
Yeah.
So, I mean, you can put beautiful veneers and beautiful crown and bridge, and then they can start cracking. And it might not have anything to do with your work. So
yeah, it's just it's getting that. Again, we say this all the time. What is your diagnosis? So figuring out what is a healthy range of motion, what do healthy jaw joints behave like? What do unhealthy jaw joints behave like? And here's the other thing. I mean, a lot of patients we have, they do have popping, they do have clicking, they do have crepitus, they don't have pain, but they're functioning just fine. When to treat, when to not treat, what's over treating, what's under treating.
What to say to patients so that they can understand it. So it's another one of those things where it's like, if we don't understand it very well, we can't explain it to our patients. And if the patients don't understand it, then they're going to blame you for something that's wrong or something that happens.
For example, true. Just so true.
Yeah. When I first started making oral appliances for patients for sleep, I had a patient who I made an oral appliance on, and there was definitely no clicking in the joints. Everything was fine. They were opening. Yeah, it's a little restricted, but not terrible, right? So it's like maybe like 38, not over 40, under 30. I mean, under 40, but not much under 40. So functional, no problems eating, those questions, right? Can you chew a bagel? Do you have problems chewing gum? All of those questions to screen for TMJ problems. Well, everything was okay. They were compensated. I know that now, but I didn't know that before. So cleared TMJ, placed the oral appliance, then the patient started clicking and popping.
Oh.
And it just scared the heck out of me. I'm like,
yes, like what is happening?
Yeah, what is happening? And in hindsight and looking back on the patient, and patient's still in my practice. So knowing her condition now, we understand that the patient had a non-reducing disc displacement, and we made it reducing, which actually improved the situation. So, but I didn't know that then. And, the patient, of course, I didn't know to prep the patient. So the patient's like, yeah, my jaw wasn't clicking. Now it's clicking all the time. You did this.
And they're like, what did you do? You made my jaw click.
What did you do?
Yeah. Right. And it's like, well, actually, you're welcome. We just reduced your disc again. I know it's annoying, but congratulations. Your joint is now on the disc, or the disc is on the joint. But yeah, it's really, it's about communication and expectations and what the patient, the doctor has to be able to communicate well with the patient and understand. And as long as the patient has a full understanding, it's just like I was actually doing some extra CE for, my DEA license. We all had to take some extra CE, at least in my state, to renew our DEA.
Yeah.
So, but one of the videos was basically, one of the courses was basically saying, if you explain to patients after surgery that there is going to be pain, and don't prescribe something for them, and then they have this illusion that they're going to be pain-free, that's where they're giving you the phone calls. They're like, this isn't working. I'm not being basically, helped through this process very well because I feel pain. They said they've just done study after study where if you just upfront tell the patient, you will experience pain. We're just trying to mitigate, maybe minimize the pain. So to expect you to feel no pain, not going to happen. You're going to be uncomfortable. They got so many less phone calls, so many less pain medications were prescribed because the patient expected it. As long as we communicate this and the patient is on our team with us, and they understand what to expect. Hopefully outcomes are a lot, a little more predictable.
And that's really great, especially when we're dealing with kids and what we do with ASAP pathway, right? Where it's growth guidance. It's like manage expectations. What we try, where are we? Where are we trying to go? What's possible? What's not possible? Where do we need your help in? Where do we need feedback? I think a lot of the TMJ patients, they don't know where to go. They don't know what's wrong with them, first of all, right? Just to get an understanding of what's happening is already reassuring to them. Now they understand. Now they know, it's not a brain tumor, right? I mean, a lot of my patients, my TMJ patients, they go through neurology, MRIs, multiple MRIs, a lot of doctors, a lot of like psych medications before they get to us, to the dentist.
Yes.
And it can be really discouraging and it can be frightening for patients to not really know what's going on.
And I think that's where the stigma even comes from too. I know Jameson talks about this, like people don't want to get into TMJ treatments and management because it brings all the crazy patients. We all hear that, like, I don't want that kind of patient in my practice. I don't want that population. And he's like, look, I mean, really, they just aren't being heard and they're not being helped. Once they're helped, and most of them, it's manageable. I mean, let's get real. I have enough in my general dentistry practice of patients. I'm like, oh my goodness,
Actually, that's so true. That's so true. And I'm going to borrow an acronym from Jameson. One of his slides is all TMJ patients are nuts, right?
Yes.
With a NUTS, and NUTS is not understanding their symptoms.
Yes. So well said.
Right. So it's kind of like, I'd go crazy too if I didn't know what was wrong with me, but I know there's something wrong with me. And I go from doctor to doctor and they can't figure out what's going on. And then you add on the component of sleep to this because there's a big relationship. There's a big crossover between patients who are symptomatic with their TMJs and patients who have airway issues. And then so if they're not sleeping well, there's a lot of studies that show that their pain tolerance decreases. So, they're
100%.
Yeah, they're
it's like they develop almost like fibromyalgia symptoms.
So all of that. So if we can get an understanding of that, we can see our patients from a different perspective and we can manage their expectations and we can talk to them at their level and just say, everything, well, not everything that we know, but explain it to them in ways that they'll understand it and that they'll be more working with you versus kind of not working with you and being angry all the time, because that's a reputation that TMJ patients have. And we're talking about the adults, right? And then now we're going to bring it down to
the kids
because ASAP pathway, right? So for kids, they don't feel anything. Actually, there's two populations that I find for kids. And the second population is kind of alarming for me. So the first population is the kids. They don't know. They don't know that there's even something wrong. The parents don't know that there's something wrong. Their jaws, when they open, they can be deviated to one side. Parents don't really
pay attention to that, right?
Yeah, or they might have a very limited range of motion. And trauma for these kids is real. How many kids do we have in our practices that play sports, contact sports?
Yes, or fall off the swing, fall down the stairs, fall off the chair at the kitchen table, multiple times a day.
It's snowing there. And what are the kids doing when it's snowing?
Right. They're out being, in my subdivision, they're being idiots, but Like, I'm like, someone's going to get hit by a car. It just makes me nervous. But yeah, kids are kids, and they fall and we check them over, everything okay? Anything broken? No. All right, let's move on. But so, I mean, in the foundations course, what are we going to learn? So what are we going to go over as far as in children, like how to identify, how to intercept, how to stabilize, how to manage?
Yes, all of that.
Awesome.
So in kids, really, the biggest concern is that the TMJ is the growth center of the mandible.
Oh yeah, good
And so
point.
if it gets injured, it's kind of like if you have a leg, right? And you have a kid that breaks a bone in the leg, it's a long bone, you break it somewhere in the middle, you allow it, you what is it? You kind of keep it stable and steady. You immobilize it.
Yeah, it reduced and mobilized the fracture.
That's right. And then you allow the fracture to heal, and then they're good. But if the fracture is in a growth plate, it's a little bit different management. You're a little bit more concerned. There's more things that you kind of have to take into consideration with regards to the healing of that. Same thing with the joints. If the disc is out, if the patient is popping and clicking, then they have a higher risk of that jaw bone, the mandible, not growing properly. You've got retrognathic mandibles that a lot of people have now. And a lot of, I would say, almost every patient that I've seen that has a retrognathic mandible that's a child has clicking and popping on the joints. So,
and how are you detecting that? Do I've heard get a little Doppler machine, a Doppler device, stethoscope, manual palpation, all of the above. What's your favorite? What's your go-to? I guess you're always going to do hands-on first, right? Yeah. Hands-on. I mean, you can feel it.
You're a dentist.
Yeah. You can feel it.
There's no better tool than your hands.
Well, you know how dentists are. Like, I need some fancy pants. I need a toy to help me. Yeah.
Yeah. What gadget should I buy for this?
Yeah,
Can
exactly.
I buy a Doppler? Yes, you can buy a Doppler. Can I buy a JVA? Yes, you can buy a JVA.
But do you have to have a JVA? Do you have to have a Doppler?
I can tell you my JVA is in my cabinet. And I can tell you that my Doppler is also in my cabinet. Do I have them? Do I have all these tools? Yes. But in a hygiene chair, in a hygiene check, when I'm screening my patients and I'm trying to figure out, is this a patient that I'm worried about joint, that I'm looking at their growth and development, or is this a patient that so everything is good? You're not going to pull out that Doppler necessarily. You're not going to pull out the JVA in a hygiene check on a child. First, it's going to scare them.
Yeah, that's like what's happening.
Right. So, perception for the patient too, right? But, if you just put your fingers there, like they're used to you having your hands on their face.
Yes, they are.
You're the dentist. It makes sense. You tell them to open their mouth, they're going to open their mouth because that's what you do as a dentist. It's not going to scare a child unless they really don't want to open their mouth, which is a different story altogether. But I try to, in my approach with children and adults, right? I think one of the things that I would love to get across to dentists is it doesn't have to be super complicated. We can do this. We can do this with the knowledge that we already have. We see so many patients every day. And if we just know what to look for, we will know who is a TMJ risk and who is not a TMJ risk. We also have to work within the parameters of our practices. We can't take 5 hours or 4 hours or 3 hours to work up a patient necessarily in our normal general dental day. It's like an airway patient, right? Are we going to be concerned with this patient with airway or are we not?
And I think too, that's another area of mystery, right? Like, how would I bill for all of this? The treatment alone is like, okay, I got to learn how to do that. But then how do you bill for this and be profitable? And you don't want it to be a complete chair time suck, and then you're like, oh, I'm wasting so much time. And, you want to be efficient.
Yes.
And know when to get in, know when to get out. and then how to be profitable as well.
I
So
will totally discuss billing and how, how to bundle things. The patients that are already being seen for orthodontics or for sleep, those really are the patients to really screen for TMD. And there's a lot of adjunctive measures that we can do as dentists who are already treating the growth guidance or expansion or sleep appliance for sleep patients. There are things that we're already doing that's affecting the TMJ, and there's a lot of things that we can do adjunctive therapies like myofunctional therapy, laser therapy, all of those things that we can piggyback to have the patient have a better experience, but also be able to bill for our services. So TMD, for the most part, is not really covered by insurance. So I do bill medical insurance for my sleep patients. I do bill the checkups, the consults and the exams, the evaluations for TMD patients. But a lot of times the treatment itself, unless they're going to surgery, they're not covered. So there's a few things that you can do to make it affordable for the patient, and also reasonable for the practice, that you're not giving this away or it's not being an expensive hobby.
yes, because we all know as dentists too, we're really good at expensive hobbies too. It's like, okay, we got to implement this. We need actionable plans,
Yes.
efficiency. That's the other thing too. You want to be able to bring it back to your team, because we all get, the eye rolls, right? When we bring something new back and they're like, oh, here she comes, or here he comes. Like,
Well, I have to
he's got
say,
something new he wants us to do. Right.
I think for TMD and sleep, those two things, when I brought them to my team, I think they're the ones who ran with it. If not for my team, I probably wouldn't be incorporating all of this really by myself. TMD and sleep, they get it. They get it. They understand it. They know that people have it. They know if you have a team that's been that has had some experience under their belt, they know that patients suffer from it, and they know that there's not a lot of dentists who are able to help these patients. So to be able to offer a service like that, I think team gets super excited to be able to say, yes, come to us. We know, well, we've helped people. We're going to try to help you, but at least we know we've been able to help other people. You can't help everybody, right?
Right. Right.
There's some patients that, there's a psych component to TMD. We're talking adults, right? Where there's
Right. Right.
components to TMD and all of that stuff. But there's also a surgical component. Sometimes it's surgery,
Yeah.
but you can help direct. It's kind of like what we do with pediatrics. Not everybody is comfortable doing expansion. Not everybody is comfortable doing orthodontics. That's why we have a team. So how do you work with a team when it comes to TMD? Who's part of your team, right? We've got ENTs, we've got rheumatologists. Those are the people that are part of our team, in addition to oral surgeons. And, so we'll discuss all of that. How do we become part of a team?
That's funny. Oh, I think I just had some reverb there. I actually had, this is so crazy. Like in the last month, I've actually had two very young patients with one of their condyles extremely small. And I brought it to the attention of, I'm like, we might need to go see, a specialist. And then they started down the path of, we might have some rheumatoid issues going on here. It's like, really, I don't know what's going on, if it's in the water or why we're seeing so much more autoimmune happening in kids, but it includes rheumatoid, and the jaw joint can tell a story there as well.
And that's one of the things that, remember I said, when we're dealing with kids, there's two types: kids who don't know that they have this, in which case it's, you're the dentist, this is our realm. TMJ is our realm. This is us. There's
There's
nobody
no plan B. It's the dentist. You got to go to the dentist.
Our wheelhouse. There's
Yeah.
nobody who's going to say, stay in your own lane, dentist. Don't do TMD,
Yeah, they're all like, please take these TMD patients. We don't know what to do with them.
Yeah, so it's up to us. So all these kids that don't have any pain, right? But they do have those symptoms. We kind of need to look out for those kiddos, and we should manage them based on what we see. But there are kids that are in pain, and the youngest I've seen, I think, is 8. That has TMD pain, like muscle and everything else. And
Mm,
then recently I have a 10-year-old who has never had ortho, right? None of those things, has never had any kind of appliance in their mouth. So we can't say, oh, it might be the appliance, or maybe it was overexpensive, like any of those things. It's
right.
not that. This
No
is just a
obvious
child.
etiology.
It-
Yeah.
it- yeah, and she has bilateral idiopathic condylar resorption. 10 years old. 10
What
years
in
old.
the world? Any trauma history?
10 years old. Yeah. I mean, yes, there's trauma history. Yeah, for this.
Mm.
But again, how many of our children are playing sports these days, and at what level? Because I feel like sports has become more intense in kids.
It has. I mean,
It's just,
your high school and middle school sports now are, I mean, they're intense.
their
And you see a
training
lot more
schedule.
injury. Yeah, a lot more injuries than there used to be. I mean, at least more serious. And you're seeing more like rotator cuff surgery, ACL surgery. I'm like, what is
At the
happening with
high
these
school, like
kids?
before they even hit college, right? Or at college level, there's already so much wear and tear that they're needing so much surgery.
Yeah.
So the level, and I see this, I dance, and I see this in dance where the acrobatics, so aerial acrobatics, what we used to do before that was considered advanced level, are being taught at beginner level now. So
Oh,
it's kind of crazy. So I like, that's the thing with sports and kids. It's like the training schedule of maybe, a pro sports person. I wouldn't say pro sports, maybe a college person. The training schedule of a college athlete is now being done by, like, I don't know, grade schoolers. I feel like there are some grade schoolers that have really, really intense training schedules. So
it's crazy. And you have these parents running their kids to these in tons of hours. And it's like, why are we doing this to them? But I think it's becoming a little too much, a little too intense.
but that's concerning. So for those kids, and they presented with non-specific, like headaches or pain in the jaw, difficulty chewing. Without imaging, I wouldn't know what I'm dealing with. I wouldn't know, like, splint therapy, great, laser, great, but that's not going to solve that joint issue. That kid's joints are basically just kind of melting away. That's not going to solve that. And if we hold off imaging until, they're adults, I don't know what situation. Hopefully, the good thing about ICR is that it's not always it's not progressive and, like, unlimited, right? It A lot of times it's limited, meaning it's gonna kind of resorb, but then it's finite, and it could be that it stays stable. So a lot of times it's not always, once it's resorbing, it's gonna resorb until you have nothing, I guess is what I'm trying to say. Right. So, but if we didn't know what the situation, if I didn't know what the situation is with this child's joints, I would manage her very differently. So that's why I think imaging, I'm a big proponent of imaging. And we kind of, as dentists, I feel like we shy away. We don't shy away from taking x-rays on a checkup visit, right? We know the value of trying to look for interproximal caries before the patient has a toothache and it's now a root canal. So, when we're dealing with something like this, I think that there's a lot of value in not being afraid to order the imaging.
Yeah.
Um, yeah, so that's one of the things we'll learn. Like,
So go back
how do
Monday,
you
how to
order the
order
imaging?
imaging
Yeah.
and
and
yeah,
and then it's like, all right, now that I have this image, what am I going to do with it? How am I
yeah.
going to read it? So how do I know that what the radiologist gave me as a result of the MRI is correct, right? If I have a suspicion that it's not right, what else can I do? Where do I go?
Yeah,
So
this is all good.
what's available, what's out there? There's a lot of things that can support us dentists. We don't have to go at it alone.
Well, I think most dentists want to hear that. They don't want to go at it alone. It's scary.
scary.
It's scary to implement something. I don't care how, amazingly intelligent any of us are. Implementation, you're new at something, right? And especially, I think the culture of dentistry, you come out expecting to be perfect at everything. I mean, it's kind of literally drilled into you to be excellent at everything. And there's not a lot of room for, hey, you're just going to have to work up to being, more proficient at this. And you have to start somewhere.
Just suck less every day.
Just suck less every day. That's it. Podcast over. Thanks, everybody, for joining us.
Anything worth doing is worth sucking at the first couple of times.
That's like the mantra of my day right now. Suck less.
You just can't. Otherwise, you're never going to get it done. You're never going to start anything new. You're never going to learn anything.
Right.
Patients are going to suffer because there's nobody else who understands it.
It's funny. It's like, I remember when I started dental sleep for my dad, it was because I had to. I was terrified. I didn't learn it in school. It's like drinking from a fire hose, right? All the information. You're like, I don't even know where to start. It's like, just start, have a mentor, have a group of people. They'll walk you through it. You're going to be fine. I think that's what people need to understand about this is you're going to be able to start. You have a group of people that will be mentoring you to walk alongside you. The worst thing to do is like absolutely do nothing and just watch it get worse, right? So let's do something. Even identifying there's a problem, like, okay, we've got a problem here. We got a diagnosis.
And even
now what?
Being able to convey that to your patient, because your patient has a rapport with you. They go to you for a reason, right? There's a personality, there's a trust. There's a lot of that established. And if you can give them some insight as to maybe why they're feeling this way, they would be more open versus some stranger telling them, oh, I think you have this, right? So,
right.
And then, if you get in over your head, just know where to refer.
And that's with anything
too.
Feel
it's, like you're in over your head. Don't
right. Don't get over it. I mean,
like
that is the other thing too, is in this course, like what to not touch, right?
When to say, yes, I can tackle this, and when to say, refer.
Because knowing what not to do is just as important as knowing what to do. For sure.
The hardest things that I had in terms of orthodontics and trying to finish and trying to get a good result is somebody who has an unstable joint or somebody who has myofunctional issues that haven't been addressed. Those are the two things that make the work so difficult. So, with TMD in imaging, you kind of know what you're dealing with. But you have to know how to work it out. So you have to know what to look for.
And then so
to give to all.
We'll have forms and everything, right? Like this is your screening form. This is your, this is how we're going to do our workup. This is our treatment plan.
This is how your auxiliaries are going to do the workup.
Oh my gosh. I love that's music to my ears.
This is how your auxiliaries will video range of motion, and you're going to see that the recording is not really me. It's my auxiliaries doing it.
Oh, I love it. I love it. Well, I mean, and that's the other thing, like even with dental sleep medicine in general in my adult and even with the kiddos, there's a lot that you can delegate, and you have very capable team members and they're on your mission with you, right? And they have the same vision for the practice, and they're making such an impact. I was just talking to Dr. Shireen Lim yesterday. So her podcast will be airing in the near future, and it was just
wait to hear that.
Yeah, she's so great. We're just talking about how awesome our teams are. And she was talking about how, I was asking how she paces out, release of tethered tissues in infants that can get kind of, babies in the office can be loud, right? Lots of baby sounds and crying. Babies just do that. And I'm like, how do you pace that? How do you manage that? And she's like, my front office team is amazing. I'm like, isn't it all amazing? Like we cannot do what we do without our team members.
Oh,
So
no.
you have a lot of video then, I guess, that you'll be showing in the course. And
Um,
like you said, recorded by auxiliary doing these things,
my
which is
team
great.
members are yeah, they love doing it too because they know that I depend on it, right? It's important. And they want to be trained, they want to learn more. I cannot do what I do without my team.
None of
And
us
yeah,
can.
and they're the ones that push me, right? You're going to get to a point where they're going to be the ones that are pushing you. There, my team pushes me. But yeah, so the beauty about our New Jersey, so this course is going to be in New Jersey, and I'm licensed in New Jersey, which is great. So we can do a lot of patient interactions.
Awesome.
You will bring, but I think dentists are great patients because we all have something because of our posture, right? So that's another thing that we use to screen is posture. But we have the course is going to be held in Florham Park, New Jersey, which is the Dawson facility, actually. So we're sharing
Oh, neat.
Dawson. Yeah. And so it's really good setup for, desk work, but it's also very good setup because we have clinical operatories. We have a dental office. So we
Must
can
be
do
great.
a lot of good stuff. And there's one thing that I'm going to talk about, which is one of the new things that I've incorporated in my practice, which is PRF. So it's joint injections and PRF injections where we draw blood, and we put it into the TMJ. So we'll talk about that, and maybe we can
Which
do.
your auxiliaries draw for you.
I don't draw.
Yeah, your auxiliaries draw. You actually, I think you sent one of your assistants for like phlebotomy training or something. Is that
I have
right?
two now. Yeah, I have two trained for phlebotomy.
So let's ask this question because there might be some docs listening right now and they're like, oh, that would be great if I could get my assistants to do the draw. And then I'm just basically injecting, which I mean, we're really seeing miracles in medicine with PRF. I mean, it's some interesting stuff. But I mean, did you have to like drag them kicking and screaming to get the training? Were they excited to get the training? They
They
were.
wanted to do it. They're like, I want to do the training next. I want to do the training next.
Well, they probably, especially when the first one that was brave, right? To do it, did it. The others are like, wait a second, I want part of the action too. So,
And the thing
um,
is, when I'm injecting and they're drawing blood, all of a sudden it's like my assistants are all in that room, So they all love it, and they all just they know that the patients come back and it's like, I don't know, like 30% better, 50% better, 70% better after being in pain for 5, 6, 7 years. And it's
that regeneration is just
amazing.
amazing.
Yeah, it's amazing to see. And it's amazing that it's such a simple, like I say the word simple, right? It's not really simple. You kind of, but if you understand the concept, it makes so much sense. So I guess that's what I mean when I say simple. There's a lot of things with TMJ that is simple because once you understand the concept, it makes so much sense. But it's that understanding the concept that I feel
Yes.
is a big hindrance because I took decades learning this and I wasn't able to incorporate it into my practice until my team was on board, and I looked at everything, and Panky, Dawson, like, and I looked at it and I'm like, they're all really saying the same thing.
Let's consolidate this information and make it, applicable and efficient. And that's what I think a lot of people are, a
So
lot
that's
of
my
people are
goal.
wanting. Yeah.
My goal is to distill everything that I've learned from all of these places, and distill it to what they have in common, what is very practical, what you can do within the framework of a busy dental practice, and what can your team help you out with so that you're not left holding the bag. I mean, you know, if I'm doing a restorative case or I'm doing a sleep case, and then there's a TMD patient that comes in and they're in pain, my team is going to bring them in sometimes without my knowledge, or just like, we squeezed in a TMJ patient. I'm like,
You're like,
okay. And
oh,
they're like, well, the hygienist is going to work them up. The assistant is going to take the CBCT. The other assistant is going to scan. They're just like piecing the people together. This one is free. That one is free. This one is free. And then the patient is in the room and they're getting service. They're getting, data. And then I can walk in and I have this information. I have the photos, I have the scan, I have the CBCT, I have the patient's symptoms, I have their range of motion video recorded already. So it's just, and then I can come in and I can sit down and get the history. Like they say, the mystery is in the history.
yeah.
Yeah. So
Yes,
it's
mysteries in the
so
history.
important. Yeah. So to just try to put it all together. And I think for TMD and for kids, it's all that data stuff that is a hindrance, and then it's the understanding. If the dentist can understand and can explain in basic concepts so that people can understand, then I think it's a win-win.
It is a win-win. Um, we've got the part one TMD foundations, May 10th and 11th that you're teaching. And
Yep.
then we have the part two that Dr. Ilya Lipkin is teaching September 6th through 7th. But what is interesting too, and I wanted to go over before, because I know we have a promo code we wanted to throw out there for your course in May. But before we do that, something that is different that we're doing in ASAP in 2024 with the CE that's being earned. Do you want to go into that? What some different options for people that are ASAP members and taking these courses, and what
Yeah.
is unique about how the CE has been set up this year, the opportunity that they have?
Okay, so I'll talk about the TMJ part one and part two and how that flows from one to the other, and then we'll talk about the protocol courses. So TMJ part one is everything that you're going to need to know to kind of to understand, to recognize, to diagnose TMD, and to help incorporate it into your practice so team members, patients can understand it, and that's basically your foundation, and you're going to be ready to deploy that from the get-go when you go into your practice Monday morning. TMD2 is all the TMD considerations when you're doing orthodontic growth and development, when you're trying to manage somebody's airway for sleep. So it's Ilya talking about how you change your treatment planning or your process for orthodontics when there's joint issues involved. And it's splint therapy, making a splint, so both will have hands-on. So the first hands-on for part one will be, how do you recognize, how do you diagnose, how do you palpate, how do you take range of motion, all of these things. What adjunctive devices can you use? Quick splint, equalizer, how do they come into play? When do they come into play? And what do they tell you when patients come back and they say, this doesn't work or this works? And then imaging. Ilya will be the splints, how to change your orthodontic treatment plan based on the TMJ diagnosis, and how to manage that orthodontics on a patient who has TMD. So that'll be Ilya. So that's
Awesome.
the hands-on there is to make a splint, different types of splint, depending on the situation.
Depending on your diagnosis. And so we got the flow between the two courses. What is different about the protocol path this
So the
year?
protocol path, a lot of people go to our courses with the intent to implement, right? This is not a course that you go to kind of just, I guess I'm going to find out more information about TMD. No. When we go to an ASAP course, be it early ortho intervention or MARPI, TADS, or the TMD, it's with the intention of actually integrating it into your practice and putting it into everyday workflow. So when we looked at the AGD criteria for a protocol course, so going back a little bit, AGD has lecture formats, right, for a CE program. They have participation format, and then they have what's called a protocol course. So lecture is lecture, participation, everybody understands. The protocol is a combination of both. And the protocol is you're going to come in, you're going to learn the protocol, and then you're going to do it in your practice. You're going to work up a patient, teach your team, coach your team, do the work, take records so that you can present the case. And then in part 2, you can ask follow-up questions. And then there's a session after part 2 where it's an online session for all our attendees. And that's when we present cases.
That's
so there's
awesome.
many different ways of learning. The lecture, hands-on, then you're going to present, right? I think the AGD awards, I think, double or triple the CE credits if you're teaching, because they know there's no better way to learn a subject
than if you're presenting it yourself.
Exactly.
So true.
Exactly.
If you can teach it, then you know it.
If you can talk about it in a
Yeah.
presentation in front of your peers, and it's a collaborative group, right? We're all really nice and friendly. It's a safe group. So we're gonna try to help you as much as we can in terms of, okay, I have a question about this. When I did this on my patient, I was expecting A, but B happened. How can I avoid that? What do I do now? All of those things, right? So ASAP Pathway courses, we have continuous support. We have the WhatsApp group, we have the Facebook group. Each class has their own WhatsApp group. And so we're doing it already anyway, before we change the format label, into a protocol course. We were already doing the protocol course. We're just formalizing.
It's official. Now we can get the credit for the protocol path. Yeah. Love it.
Because it's a protocol path, all of the credits become participation. So for those people that are working towards their fellowship in the AGD or mastership in the AGD, this is a really good way to accelerate into those milestones, because everything becomes participation. And then we also take into consideration the time it takes to see the patient, to prepare for the patient, to prepare for your presentation, and to do the presentation. So it's an opportunity to earn a lot of CE credits if that's one of your goals. But really, at the heart of it is, this is a way for you to really get through your first case. For ASAP members in the group and the instructors to hold your hand and guide you so that you can do this in your practice. And if you're doing it already, then we can help you get to your next level.
Awesome. I'm excited about it.
Yeah.
Do you have a promo code that you're wanting to share? And then I could also put this code and then obviously the link for these courses, but I'll stick the promo code in the information for the podcast.
Yeah, so it's $500 off the May course. So the promo code is TMJ May 2024. And that's good till March 15th. So again, TMJ May 2024, $500 off that part 1.
And it expires March 15th, correct?
Did I say May 15? Yeah.
I think you may have, but maybe you did not. I was just repeating it. I think it expires March 15th for the course, May 10th and 11th. Well, thanks for coming on today. I love this topic. It's still like the mysterious TMJ to a lot of people, and I'm really excited to dive in and learn more about it. And I am so appreciative that you're putting all your hard work and knowledge together and just simplifying and consolidating the information, because I think that's what people want. They just want it consolidated. What's the right way to do this? Where I can help. Maybe I'm not helping every single person, but can I help most people that walk through my door? That's what we're looking for, right?
Absolutely. And you have patients in your practice already that need this work. The first couple of years when I started doing this, I didn't see patients outside the practice. I just limited it to the patients that are in the practice, and we were busy. So now a lot of my patients are being referred by physicians, other dentists. But yeah, in the beginning, we didn't advertise. We couldn't handle the volume. Once you identify and once you start talking to the patients, it's just like airway. Once you identify and once you start talking to the patients, you're going to find that your patients in your practice have this need. So
I do. It's a lot. And I really do feel post-COVID, boy, we had a huge increase and uptick in bruxism and clenching and a lot of parafunctional activity and just anxiety in general. So I think the population, actually the need definitely increased in the last few years. Well, thank you so much, Michelle. I appreciate you so much. We talk pretty much every day, all the time, but it's really nice to connect.
Tuesday, every day, all the time.
Every day, all the time. I wake up. Where's my text from Michelle and Tracy? Something's wrong if I don't see.
Right?
Yeah, I'm like, is everybody okay?
Like, what's going on? I haven't heard from Stacy.
I haven't heard in a whole day. How is everybody? And then we'll say, I'm just going to take a break today, right? I'm going to take some time for myself. And an hour later, I can't help myself. I'll send
like, Stacy, I thought you were taking a break.
Yeah, so sorry. I can't help it. I have an addiction to my ASAP family. Okay. Well, thanks everybody for joining us. And I really hope we see you all at the course in May. And then again, part 2 in September. Thanks for coming on today, Michelle.
Thank you so much. And if anybody has any questions, they can just email me directly or reach out to any of our info@asappathway.com or Michelle@asappathway.com.
Awesome. Thanks, everybody.
Take care.